So I just wanted to say that it's an honor and a privilege to be here today and to speak to you, and I commend all you because I know it's such a difficult diet, but it's a good diet. So today we're going to be talking about, and I want to just thank Jeffrey for all his hard work too. Yay, Jeffrey. Today I'm going to be talking about IBD and SCD, when, how, and why to supplement. The objectives of today's talk are to understand that the SCD provides nutrients to heal the gastrointestinal tract and improve immune function, to recognize that any diet can be low in any nutrient, so can the SCD. Realize that some nutrients protect against IBD, others may be beneficial, and know when and how and why to supplement. The SCD works by removing disaccharides and polysaccharides. The diet was developed to starve inflammatory bacteria and change the microbiome. Dr. Susskind has proved that in his, in one of his studies, and to improve the microbiome for the better. By removing these disaccharides and polysaccharides, automatically many other inflammatory components are removed from the diet, which have been studied in relation to Crohn's disease and ulcerative colitis. Those are polysorbate 80 and carboxymethylcellulose, which are two emulsifiers. They've been shown to cause the adhesion of inflammatory bacteria to the cell wall in the intestine. Maltodextrin is a binding agent, and that is in many processed foods also, and that also has been shown to cause the adhesion of E. coli, a pathogenic bacteria, to the intestine wall. And gliadin, the protein in gluten, has been shown by Fasano and his group to cause the release of zonulin in the small intestine, which increases intestinal permeability. In addition to eliminating many foods, foods that are inflammatory and cause dysbiosis, the diet also provides foods which heal and support immune function. As a dietitian, I listen to what children eat all the time. And not all children, but most children do consume a standard American diet. One high in sugar, processed grains, unhealthy fats, and fats that the body kind of honestly doesn't recognize. And low in quality protein, fruits, vegetables, and healthy fats. So in other words, children and adults, if they're consuming that kind of diet, are not going to heal themselves, or they're not going to get better by eating a diet like that. They're actually consuming foods that perpetuate inflammation. So anytime a patient wants to start the SCD, it makes me very happy because I know that in addition to removing these foods that affect the microbiota negatively, they're eating foods that heal the gastrointestinal tract and decrease inflammation. The diet contains quality protein that protects against inflammation, and in pediatrics it's really important for growth, and it repairs the epithelium. Antioxidants and phytonutrients found in different colored fruits and vegetables that decrease oxidative damage and pick up free radicals and have anti-inflammatory effects. Real fats that the body can absorb and recognize, like omega-3 fatty acids that stop the inflammatory cascade, and saturated fats that have antiviral and antibacterial effects. Probiotic foods like yogurt and fermented vegetables that decrease inflammation, increase tight junctions, and produce antioxidant enzymes. And lastly, fiber and prebiotic foods that repair the colonic epithelium, stimulate the growth of good bacteria, inhibit the growth of inflammatory bacteria. The SCD is also balanced. It contains all 3 macronutrients: carbohydrate, protein, and fat. It's not a low-carb diet as one would think. It's specific, as the name indicates. And on this diet, I know children, and I'm sure that adults, consume healthy foods, fruits and vegetables in quantities that many of them have never consumed before. So you ask, why would a patient on the SCD with all this good food, why would they need to supplement? And it is a good question, but I know any time that you remove foods from the diet, there's a chance that you may have a deficiency. And I see patients, and when they go on the SCD, sometimes I'll see them and I never see them back, or any diet that you take something out. And as a mother of 3 adult children and a nutritionist, I worry that they're not getting everything they need, because an initial appointment, it's almost overwhelming to talk about the nutrients and everything. You just want to tell them what they can and can't have initially. So reasons why to include, why you would supplement are nutrient deficiencies are possible in any diet that excludes foods. So as a dietitian also, when you take out grains, you decrease dairy, you think B vitamins, iron, calcium, vitamin D, and naysayers of the diet would say, oh, this diet is not good, but we know better than that. Picky eaters, this diet is actually an antidote for picky eaters. I'm sure many clinicians here have seen, once you take the sugar out of the diet, I know children eat foods they have never eaten before. But in the same breath, people eat the same foods every day. I see that. I see they have the same breakfast, the same lunch. Allergies and tolerances can limit the diet further. For example, now I have a patient on the diet that has an allergy to eggs and nuts, so that patient needs to be supplemented. I've had patients in the past that have an oral allergy syndrome or problems with oxalates. Can limit the diet. Many patients have greater needs for specific nutrients because of their health history, environmental exposure, or medications. For instance, 5-ASAs, which are common drugs that are usually used in IBD, they deplete the body of folate, so folate needs to be supplemented with a 5-ASA. Drugs like Pentasa, Azicol, mesalamine. We're all different and have different body chemistry. So, we have unique requirements. So for instance, I may need more B6 than you because that's the way I'm wired. Lastly, inflammation of any kind causes increased nutrient needs in the GI tract, especially where inflammation affects the absorption of nutrients. IBD causes nutrient deficiencies. These are the most common nutrient deficiencies in IBD. Deficits are more common in Crohn's disease because more nutrients are absorbed in the small intestine than ulcerative colitis. Reasons for deficiency include oxidative stress, diarrhea, gastrointestinal bleeding, medications, reduced appetite, malabsorption, avoidance of foods, inflammation, and exclusion diets. With IBD, often the areas of inflammation or resection, if a patient has had surgery, determines the need for a particular nutrient. For example, B12 is absorbed in the ileum, so for those with inflammation or removal of the ileum, they're at increased risk for vitamin B12 deficiency. So in IBD, it's important to understand what areas of the gut are affected by inflammation. The nutritional adequacy of the SCD was evaluated by Dr. Suskind and Kimberly Braley, the dietitian that works with him at Seattle Children's. They analyzed 3-day diet records of 8 patients at 2, 4, 8, and 12 weeks for 20 nutrients. These results were compared to the recommended dietary intakes in diets of children their own age. The results of the analysis were more than this, but they showed that the SCD was adequate when compared to the diets of similar aged children. So even though we know that the SCD is better food quality, but even though the SCD excludes foods, it was not lower in nutrients, than patients who are on a regular diet. And for the majority of nutrients, the SCD exceeded the recommended dietary intakes. The SCD was below the RDA, or recommended dietary intakes, for vitamin D, calcium, B1, folate, zinc, and phosphorus. The numbers next to those vitamins, like vitamin D, 100%, that means 100% of the patients were low in vitamin D. Or calcium, 75% of the patients' diets were low in calcium. And the study mentions, we need to keep in mind this is only 8 patients, so definitely more studies are needed. And the other thing that the article mentioned was that the RDAs are estimates for healthy people to alleviate nutrient deficiencies. We don't really have a standard of nutritional adequacy in IBD. IBD patients may need more. So this is a 3-day dietary analysis that I did. It's not a study, but it took me a long time, so I wanted to, and I think the information is good. So what I did was, there was 6 patients, and I just did one 3-day dietary analysis, and it looked at 22 micronutrients and macronutrients. And what it showed was all the diets were low in vitamin D. The majority of intakes were low in calcium, and when I say low, low is less than 50% of the RDAs. Many intakes were low in different B vitamins. But the interesting thing was that all were low in essential fats, omega-3 and 6. But again, it's not a study. But this is exciting. The ratio of omega-6 to omega-3 was ideal. And omega-6 are fatty acids that aren't bad in themselves, but when the ratio of omega-6 to omega-3 is high, it's inflammatory, and that was good. So the nutrients we're going to discuss today are vitamin D, folate and B12, and zinc. Vitamin D, folate, and zinc could be low in the SCD. B12 was not low, and it probably is not, but folate and B12 work together. And the thing about these nutrients, they actually protect against IBD or complications of IBD. Thiamine and calcium seem to be low in the diet, or may be low in the diet. Omega-3 fatty acids, probiotics, and curcumin may be beneficial. So I'm going to power through some nutrients here, and I have a lot on the slides, and I don't want it to be distracting at all. So what I'd like you to do, if you're on the diet or somebody you love's on the diet, just to sort of pay attention to what foods contain the nutrient, and evaluate, do you eat any of those foods at all? Secondly, there are symptoms of that deficiency of the diet, and at the end of each nutrient, I review reasons to consider supplementing. So, so that's what I want you to pay attention to. Vitamin D is important because it protects against IBD. There's a strong accumulating evidence in animal studies that vitamin D and vitamin D receptors regulate intestinal inflammation. These studies also show that a deficiency in D worsens colitis and alters the microbiome. Data from the Nurses' Health Study, a huge prospective study, showed that increasing blood levels of vitamin D from 22 to 33 was associated with an almost 50% reduction in the risk of developing Crohn's disease. So just getting your blood levels up 10 points was a 50% reduction. Also in Crohn's disease, when patients were given 1,200 international units of D3 for a year, this reduced relapse rate by 50% compared to placebo. Low vitamin D levels are associated with more surgeries, hospitalizations, and loss of response to drug therapy. Climates where there is less sun exposure, so IBD is more prevalent in northern climates where there is less sun exposure, and that's because it's the sunshine vitamin, and because we should be getting most of our vitamin D from the sun, but we can't, or we're indoors most of the time. Vitamin D is absorbed in the ileum. It's a fat-soluble vitamin referred to as the sunshine vitamin, as I said. We absorb vitamin D on the skin, and it's converted in the liver to be used by the body. When we think of vitamin D, or when I think of it, because I'm old, you think of bone health. But research over the past 20 years has shown that almost all tissues and cells of the body have vitamin D receptors and show vitamin D activity. It's heavily involved in the immune system, and it's involved in the regulation of over 2,000 genes. Symptoms of deficiency include profuse sweating, chronic levels of inflammation, muscle pain and muscle weakness, heaviness of legs. I just saw that symptom with a patient with vitamin D a few weeks ago. Shortness of breath, that's what SOB is, scaly lips, and conditions such as osteopenia and osteoporosis. Vitamin D is considered low if serum D levels are less than 20 NGs per milliliter. Vitamin D, the recommended intake for children and adults is 600 international units. There aren't many food sources of vitamin D. It's primarily in fatty fish like salmon, tuna, and sardines. Reasons to consider supplementing vitamin D is that vitamin D was found to be, vitamin D is it's common deficiency in patients with IBD. You would supplement it if there's extensive inflammation in the ileum or a patient has had surgery, low sun exposure, which applies to most people, and drugs like steroids and cholestyramine interfere with its absorption. Most patients with IBD should consider vitamin D, taking 600 to 2,000 international units to maintain blood levels at 40 NGs per milliliter. Most multivitamins have between 400 and 1,000 international units. If deficient, a therapeutic dose should be prescribed by your doctor or healthcare practitioner. D3 is well absorbed. D3 is better absorbed than D2, and vitamin D should be consumed with fat because it's fat-soluble vitamin, so at a fatty meal or a fatty snack. B12 and folate, as I said, work together. They protect against IBD and complications. They're important because low levels of folate, B12, and B6 are associated with high levels of homocysteine in the blood. Homocysteine is a toxic amino acid that damages blood vessels and plays a pro-inflammatory role in IBD. Also, B12 and folate are involved in the development of the microvilli in the small intestine. The microvilli contains enzymes to digest carb, protein, and fat. If the microvilli is sparse, then digestion is affected and dysbiosis occurs. In addition, low levels of folate have been, with high homocysteine levels, have been shown to increase risk of colon cancer, while supplementing folate prevents folic acid depletion and may reduce the risk of colon cancer. Folate is absorbed in the jejunum. It's important for cell metabolism. It's a cofactor in what is known as the methylation cycle and is involved in the synthesis of RNA, DNA, red blood cells, white blood cells, and neurotransmitters. Symptoms of deficiency include poor growth, fatigue, depression, inflammation of the gums and or tongue, brown spots or patches on the face called melasma, shortness of breath, and tingling or numbing in the hands and feet, which is called peripheral neuropathy. And there's a certain type of anemia called megaloblastic anemia that's specific to B12 and folate deficiency. The recommended intake is 400 micrograms for adults. Folate is found in mostly plant-based foods, all plant-based foods, green vegetables, legumes, nuts, and some fruit. Reasons to consider folate supplementation is if you take a 5-ASA drug, such as Azicol, sulfasalazine, Pentasa, or methotrexate. PPIs like Prilosec or Prevacid interfere with folate absorption, and birth control uses all B vitamins for its metabolism. Folate needs are increased during pregnancy and lactation. It's used to metabolize alcohol, so more folate is needed if alcohol intake is high. Conditions such as megaloblastic anemia or homocystinemia call for folate supplementation. The 1 milligram per day for patients taking 5-ASA agents are deficient, And if dietary intake is low, a multivitamin or a B complex should be given. A lot of the SCD legal multivitamins are high in B vitamins. B12 is absorbed in the terminal ileum. It's important for cell metabolism, especially in the GI tract. It works together with folate and many biochemical pathways. It also has neurological functions and produces neurotransmitters. It has many of the same deficiencies as folate. Clinical clues that are specific to B12 are poor balance, or dizziness is a big one, muscle coordination. Many Bs have neurological or psychiatric conditions like memory loss or depression. The recommended intake for adults is 2.4 micrograms. B12 is found in all animal sources, meat, seafood, eggs. SC foods are not usually low in B12. B12 supplementation should be considered if a patient has extensive inflammation in the ileum or has surgery. 30% of patients with Crohn's disease have small intestine bacterial overgrowth, that's SIBO, and so this causes B12 deficiency. Low stomach acid or gastritis will affect B12 absorption because B12 is needed to separate B12 from the food that is eaten. So any medication affecting or controlling acid, such as antacids, H2 blockers, PPIs, affect absorption. A person who follows a vegetarian diet will need B12 if they eat little meat or seafood. Fatigue is a huge clue for B12 deficiency. B12 is supplemented intramuscularly, 1,000 micrograms monthly if ileal resection is greater than 60 centimeters. 1,000 micrograms by mouth is the dose to be given if there's a deficiency. And if taking folic acid or any B vitamin, it's a good idea to take a B complex because they work together. Zinc also protects against IBD. Zinc levels have been found to be lower in patients with IBD than healthy controls. High doses of zinc, 110 milligrams 3 times a day for 8 weeks, decreased intestinal permeability in Crohn's disease patients for 12 months. Data from a prospective study looking at 773 patients with Crohn's disease and 223 patients with ulcerative colitis showed zinc deficiencies were associated with poor clinical outcomes. Also, the normalization of zinc levels was associated with improved outcomes. Studies done with mice have shown that administration of zinc improves intestinal barrier function as well as decreasing inflammation, and also that zinc deficiency is associated with severe colitis. Zinc is a mineral. It's unclear. Some references say it's absorbed throughout the whole small intestine. Another reference said the jejunum, so I'm not really sure about that one. It's an important cofactor in over 200 reactions in the body. It's involved in protein, collagen, and DNA synthesis. It has hormone activities, and it's critical to immune function, sexual maturation, and overall growth. Zinc deficiencies include loss of taste and smell. In children, pica, the eating of non-food items, and picky eating. Poor growth is a big one. So any child that's not growing, zinc should be checked. Any condition of the skin or hair loss, and peeling of in the hands, the palm of the hands and the sole of the feet. And I have seen that in a few patients. Bowles lines or white lines on the fingernails. The recommended intake are 3 to 8 milligrams for children, 11 for adults. Good sources of zinc include red meat, liver, seafood, and eggs. Nuts and beans also contain zinc, but zinc found in plants is not as bioavailable to be used by the body. These foods are high in phytates, which compete with zinc for absorption. Clues to consider zinc supplementation are skin conditions, acne, eczema, dry skin, chronic diarrhea, frequent infections, children with short stature, and slow sexual development, and growth in general is very common. Anyone who is consuming a vegetarian diet, one low in animal sources and zinc high in phytates. Short-term supplements at higher levels may be beneficial for 2 to 3 weeks. They should be supervised because zinc is toxic. A safe supplemental range is between 15 and 45 milligrams if given 1 to 2 milligrams of copper, because excess zinc may cause a copper deficiency. Thiamine. The evidence to consider B1 in IBD is not as compelling as other nutrients we have discussed, but the Seattle study showed that it was low in patients consuming the specific carbohydrate diet. And also, thiamine is a nutrient that needs to be consumed almost daily because it's not stored in the body as other nutrients are. I did find 2 studies. One showed that high doses of vitamin B1, or thiamine as it's called, corrected optic neuropathy and ocular palsy in patients with ulcerative colitis, and another showed high doses alleviated fatigue in Crohn's disease patients. Thiamine is absorbed in both the jejunum and the ileum. It's important for energy metabolism, carbohydrate metabolism, and neuronal and neurocognitive function. Low levels of B1 lead to energy failure, oxidative stress, and mitochondrial abnormalities. Symptoms of deficiency range from cough, tenderness, irritability, depression, insomnia, fatigue, to ataxia, loss of reflexes, and cardiomyopathy. Children need from 0.4 grams at 1 year to 1 milligram at 18 years. Adult women need 1.1 milligram, and adult men need 1.2 milligram. The best SCD food sources for thiamine are pork, seeds, nuts, and legumes. Someone may need a thiamine supplement if they have increased activity. Adolescent kids with Crohn's disease that are athletic may need more because it has to do with energy metabolism. Certain foods are antagonistic to B1 absorption, and these are tea, coffee, beets, Brussels sprouts, and raw fish. They actually interfere with B1 absorption. And low folate. B1 is poorly absorbed in cases of folate deficiency. Another good reason to take a B complex. If deficient, safe supplemental ranges fall between 100 and 200 milligrams per day. If dietary intake is low, a multivitamin or a B complex. Calcium. Calcium is important because it's low in the intake of most patients with IBD, studies have shown, and that's because a lot of patients can't tolerate dairy. It's important to maintain bone density, and this is important. Calcium must be adequate before taking vitamin D supplements because vitamin D mobilizes calcium from the bone. Calcium is absorbed in the duodenum and jejunum. It's most abundant mineral in the body. The majority of calcium is used as part of the mineral mixture that builds strong bones. It's also needed for muscle and nerve function. Symptoms of deficiency include abnormal heart rhythms, palpitations, twitches, hypertension, again, peripheral neuropathy, insomnia, and conditions such as osteopenia and osteoporosis. Recommended intakes range from 700 milligrams during childhood years to 1,300 milligrams at adolescents and 1,000 milligrams for adults. SCD sources include the SCD sources of dairy, fatty fish, almonds, almond flour, and dark leafy greens. Reasons to consider calcium supplementation besides the obvious are someone who consumes excess protein, which can be the case in patients on the SCD because excess protein encourages calcium loss through the urine. Other factors which affect calcium absorption are excess intake of caffeine, alcohol, and fiber and oxalates. Oxalates are found in dark leafy greens, beans, nuts, seeds, and they bind calcium and inhibit absorption. Supplement calcium by determining how much is coming from food. So usually when I see a patient, I try to get half of the calcium intake at least from food. That should say 1,000 to 1,500 milligrams are needed depending on age. Multivitamins generally have about 100 to 200 milligrams. It's good to know that only 500 to 600 milligrams can be absorbed at one time because you don't want to have your SCD yogurt and your calcium supplement at the same time. Calcium citrate is best absorbed, and calcium needs vitamin D and magnesium for absorption. Omega-3 fatty acids. Omega-3 fatty acids are essential, meaning they need to be consumed. So a few of the most important omega-3s are ALA, which is alpha-linoleic acid, EPA, and DHA. They're important for eye and brain development and function, fat metabolism. They form membranes in every part of the body and regulate immune function. Sources of omega-3 include fatty fish like salmon, sardines, and vegetable sources like walnuts and legumes. However, vegetable sources need to be converted to EPA or DHA to be used by the body, so seafood is the best food source. Symptoms of omega-3 deficiency include skin problems, including keratosis pilaris, which is the chicken skin on the back of the arms and face sometimes. That's also vitamin A. Also, vision function and neurological symptoms of anxiety, OCD, and attention deficit disorder may be attributed to omega-3 deficiency. Animal studies, epidemiological studies, and prospective studies have shown that an increased ratio of omega-6 fatty acids to omega-3 fatty acids in the diet causes inflammation and increases the risk of IBD. Omega-6 fatty acids, like omega-3, are also essential and not bad in themselves, but high levels of omega-6 to omega-3 promote inflammation. Omega-6s are primarily found in packaged processed foods such as sunflower oil, safflower oil, and soy oil. So the Western diet, or the standard American diet, the typical ratio is 1 to 10, or in bad cases, 30 to 1. The recommended or ideal is 1 to 1, and the Mediterranean diet has a ratio of 4 to 1. The SCD, by eliminating packaged processed foods, improves the ratio naturally. And in the 3-day diet analysis that I did, this can be seen. Reasons to supplement omega-3s would be no fish in the diet. With ulcerative colitis, I didn't go over this, that in human studies, the evidence for using omega-3s is better than Crohn's disease. And deficiency symptoms. If dietary intake is low, 1,000 milligrams of EPA plus DHA is recommended. When a patient has been on the diet for a while, I think it's a good idea to do a more balanced omega supplement of omega-3, 6, 9, just to make sure you're getting things in the right ratio and you're getting enough. 3,000 to 5,000 milligrams in patients with ulcerative colitis was used in most studies. And some FYIs are that they cause increased stools, so if you're having a flare and a lot of diarrhea, you don't want to stop those immediately. They have blood thinning effects, and fish oil can have mercury in it, so you want to make sure you get a good supplement that's molecularly distilled. Probiotics. Probiotics are beneficial bacteria that have many functions in the GI tract, including killing inflammatory bacteria, inhibiting the growth of pathogenic bacteria, and nourishing the intestinal lining. SCD probiotic foods include the SCD yogurt, which is homemade, sauerkraut, which is homemade, and fermented vegetables. I didn't go on, sorry. The microbiome of the gut, or the bacteria in the gastrointestinal tract, has been shown to be different from healthy individuals in that it's characterized, as was said earlier, by a decrease in richness or an increase in richness or biodiversity, and an increase in pathogenic bacteria, and an increase in pathogenic bacteria and a decrease in beneficial bacteria. So you would think that a probiotic may help in IBD. However, research has shown that probiotic supplementation in Crohn's disease is ineffective. The results of studies have been more promising in ulcerative colitis. VSL-3 is one that has been studied and been shown to induce remission and helps prevent pouchitis. It's not SCD legal. Other species have been successful in improving clinical symptoms and maintaining remission in ulcerative colitis. So the research is definitely stronger for using probiotics in ulcerative colitis than Crohn's disease. The thing to remember in these studies is these studies were all done with no diet change. And so I know I see a lot of different patients with GI complaints, and I would, if they don't change their diet, I know that a probiotic may help a bit, but it's not the answer. So I guess the questions to ask are, how do we supplement with diet change? Do we use single or multi-strains? And I don't think anyone has the answer to that yet. The earlier speakers said that. We definitely need more studies to determine what exact species and the appropriate strength. Research has shown, though, that a specific probiotic, F. prausnitzii, is low in patients with IBD, and it's protective against IBD. It's not available as a supplement. Prebiotics, which are a type of fiber that ferments in the colon and feeds probiotics, along with other types of soluble fiber, feed this F. prausnitzii bacteria, increase bifidobacteria, and other butyrate-producing bacteria. Butyrate is the primary colonic fuel. So a good way to increase probiotics in the diet, and specifically F. prausnitzii and bifidobacteria in the gut, is by consuming SCD sources of prebiotics and soluble fiber listed here. Reasons to consider supplementing probiotics in IBD are patients with ulcerative colitis, those with a history of antibiotics, or food allergy, or recurrent infections. Saccharomyces boulardii is a yeast bacteria that has been shown to be helpful. It actually improves or attenuates the drug therapy or the antibiotic therapy to help that bacteria go away. It also has been shown to help in Candida albicans. So how to supplement probiotics is to first use probiotic foods, which are primarily lactobacillus species, and plenty of prebiotic foods, which feed bifidobacteria and lactobacillus species. There's no established guidelines. Everyone's microbiome is different. If supplementing, definitely use SCD formulas. And Saccharomyces boulardii should be used short-term with infection, candida, and should be supervised. And lastly, curcumin. Curcumin is the active yellow pigment of the turmeric spice. It's an herb belonging to the ginger family. Research has proven that it decreases inflammation in IBD. It works much like drug therapy, targeting mediators of inflammation. Studies have demonstrated the promising role with children and adults. In a multi-centered, double-blind, placebo-controlled trial, patients were randomized to receive 1 gram of curcumin twice daily. During the study, relapse rates were lower in patients taking curcumin, 4.65% versus 20.5% in the placebo group. Another randomized trial, patients with ulcerative colitis were taking either 3 grams of curcumin or a placebo. After 1 month of treatment, the percentage of patients in clinical remission was higher than in the group receiving curcumin. Curcumin is safe. Human clinical trials have established curcumin safety, tolerability, and toxicity. David Suskind and his group looked at 11 pediatric patients. Curcumin was given at 1 gram daily to start and increased to 4 grams for 3 weeks with no significant side effects. There is no recommended dose. The studies use 2 grams per day to maintain remission and 3 to 4 grams to promote remission. FYIs, it has blood thinning effects and bioavailability is limited, so a quality supplement using black pepper or a patented formula is suggested. So to conclude, our key takeaways. In addition to altering the microbiome, the SCD provides nutrients to heal and improve immune function. Any nutrient in any diet can be deficient. Nutrient deficits may contribute to the development or perpetuation of IBD. So deficits need to be corrected by increasing food sources and supplementation. With SCD, a multivitamin mineral and vitamin D should be supplemented. Additional nutrients may need to be supplemented if low in the diet, symptoms are present, drugs interfere with absorption, or lab values indicate. Other supplements may be beneficial. A random biochemist wrote this, but I agree with this guy. A vitamin is a substance that makes you ill if you don't eat it. And here are some supplement recommendations. Thank you for your attention.